Hello, good afternoon. I see that the participants are slowly coming in. I hope everyone is having a lovely Tuesday. My name is Tafadza McConnell. I am a supervisor with the court support at the PUA courts in Newmarket. I am here to introduce Steve Halvanek and Connie Coburn, who will be speaking about acquired brain injury system navigator. Is that let's make sure I get the full name for that. I apologize for that. I'd like to first start off by giving a, oops, my notes are a little messed up here, sorry about that. Giving a little notion, acknowledgement. So I acknowledge the land we are meeting on today is located on the traditional territory of many Indigenous peoples, such as the Anishinaabe, Haudenosaunee, Huron-Wendat, and Métis peoples, and the treaties of the Haudenosaunee Mississaugas of the Credit First Nation and Williams Treaties First Nations. This land is now home to many diverse Indigenous peoples. The land that I'm standing on today, York Region, is located with the boundaries of the Nanfam Treaty, Treaty 13, and the Williams Treaties. There are also other land claims and treaty rights involving portions of York Region that have not been resolved. The Chippewas of the Georgina Island First Nations is in the Williams Treaty First Nations and is the closest First Nation community to York Region. Today, we are speaking on the again with Kathy Halovanik. Kathy is an acquired brain injury systems navigator for the Central Region of Ontario and provides intake services to community and head injury services, also known as CHIRS in Toronto. And she has worked in the field of brain injury since 1995 and has experience on the front lines as well as behind the scenes. Also with us today is Connie Coburn, who is a RN and a certified life care planner of Canada, and champion acquired brain injury systems navigator. Connie is a registered nurse who has focused her practice in acquired brain injury, also known as ABI, with a background as a case manager for catastrophic injuries. Connie has transitioned into the role of systems navigator for acquired brain injury with Ontario Health at Home in the Champlain region. Champlain region. So these bios for our esteemed guests today are the full list of the bios for these esteemed guests today is going to be listed on the website. Please see the website for a more in-depth bio on both Kathy and Connie. And without further ado, I'd like to pass it over to Kathy and Connie. Midway, thank you. Merci.
Thanks, Tafadza, and thank you to Justice Barnes and the Association for Justice and Treatment Professionals for inviting Kathy and I to speak today on brain injury. And really today we're going to talk about connecting the dots for individuals living with acquired brain injury that also have complex needs due to other issues. So we're going to really work through 5 goals today in our discussion. We're going to talk about the role of the ABI System Navigator and how you can make use of their services in your environment, to understand the high prevalence of brain injury that you are already encountering in your setting, even if you don't realize it, and how to screen for it, to recognize the presentation of brain injury, and some strategies to support someone with an acquired brain injury. And lastly, we want to make sure that we're giving you resources, and we're going to focus on the central link ABI Resource Library. So to start off with, there are 13 navigators across the province of Ontario, and this position of System Navigator for Acquired Brain Injury was created in 2010 with the goal being to link people who have an acquired brain injury with the healthcare system so that they can have access to the resources they need. And there's 4 pillars of the role of navigators. One is education, to increase the awareness of brain injury, to provide training in screening for brain injury and to support individuals that have brain injury, as well as making sure that they're aware of general resources in the community. And that goes along to the resource navigation. So helping people get the resources that are gonna meet their individual situations. And then complex case coordination. So as individuals are looking at transitioning into the community, possibly from a hospital or on release, looking at what supports are available in the community to maximize their rehabilitation as well as their functioning in their environment. And lastly, to identify system gaps and barriers that are in relation to acquired brain injury and how we can support people. So we're really looking at helping professionals, caregivers, people with lived experience to connect to those resources. Within the slide deck that we will send along, there is the list of all of the navigators. So the 13 navigators correspond to the traditional LIN regions. And this way, if you are looking to get some supports and resources, you will have the contact information so that you can connect with them. So we spoke about the pillars of our roles as system navigators for acquired brain injury, but in addition to that, each of the navigators in the LIN regions has other projects that they're working on. And so this might include community reintegration tables, streamlining the pathways of care, developing the central link resource library. One of the areas developed a program called ABI in the Streets to respond to vulnerable and the homeless population. And there's also a training for ABI in the context of PTSD and how to support individuals with those that dual diagnosis. So there's information about each of the programs that are taking place across the province, and that will also be in the slide deck. So let's go on to what really is brain injury. When you look at brain injury, it's really divided into two categories. One is non-traumatic brain injury, and the other is traumatic brain injury. When we think of non-traumatic brain injury, sometimes referred to as acquired brain injury, you usually think of an internal source. So it's something inside your brain that is impacting the function. So that might be something like a lack of oxygen to the brain cells. You'd see this in a medical situation like stroke. You could have an anoxic situation like strangulation, where the brain cells aren't getting oxygen, poisoning by either a noxious substance, or in the case of something like Korsakoff syndrome, there's an excess ingestion of alcohol, which can cause a thiamine deficiency, thereby impacting cognitive changes. Could be a virus that's impacted brain function, and it could be a tumor. So because the skull is a rigid, bony structure, if there's a mass within your brain, then it's going to cause the other cells to have constricted space, and so that can impact function. So that's all non-traumatic or acquired brain injury from an internal source. And then alternatively, we have traumatic brain injury, which is due to an external source. So we typically think of, in our area of living, there's lots of falls in the winter and people hit their head and can have a concussion from that. Motor vehicle accidents, either them striking their head on the windshield, or if someone's not wearing a seatbelt, them being ejected from the vehicle and striking their head. Could be being struck by another object or assault. It could be sports injuries, or it could also be explosions. So the military's identified that blast force brain injury was the signature injury of the Iraq and Afghanistan wars. So those are the two types of brain injury. And it's important to note that typically when someone has a brain injury, they're classified either as severe, moderate, and mild. But you need to keep in mind that someone even with a mild brain injury can have very significant functional impacts and long-lasting impacts. The unique thing about brain injury is that because your brain is the central computer for everything, that when there's an injury to the cells in the brain, it affects the whole body. So it can affect physical function, cognitive function, the ability to communicate, emotional presentation, and behavioral responses. And if you look at this map of the brain, it identifies the areas of the brain and some of the predominant functions those different areas have. Today, we're going to look at some of the common changes after acquired brain injury. So we've broken them down into 3 categories: the cognitive changes. So cognitive is the mental processes of the brain, the behavioral challenges that sometimes happen after brain injury, and physical. So if we start with the cognitive, and you think about someone in your setting. So I want you to think of someone that you think might be struggling with brain injury. Sometimes they have memory issues, and it can be short-term memory or long-term. Or the other thing that we often talk about is working memory. So working memory is when you have a piece of information that's at the forefront of your brain that you need to use. One example being if you're trying to remember a telephone number and then you're going to input that into the telephone, you're having to use that memory to actually operate the phone, right? So any of those can be affected due to brain injury. Attention. So if you're talking to someone, and you might be thinking about someone now that you've been connecting with, and you find that they really can't process information for very long. So they don't attend to the information. It could be written information, it could be verbal, and you just don't seem to be able to keep their attention. But then they also can't process that. So they can't take that information and make sense of it in order to come back with a response. That can be from brain injury. Planning and organization, and this can be something simple like planning your groceries. What are you going to eat the next week? Up to, how are you going to organize how you're going to go through the court system and what supports you need and what's going to happen next. So all of those can be impacted by brain injury. Then judgment and insight can also be a big challenge. Their ability for someone to really work in the wise part of the brain. So we often talk about the rational or logical part of our brain function, and we talk about the emotional. And sometimes with brain injury, things sway to one or the other, right? We act completely on emotion, or we act completely on logic without any emotion. And we're really hoping people act in more the center part of the wise part of their brain. The other thing is mental inflexibility or flexibility. So their ability to move from one process to another. So if they have information, they're talking to someone at the same time, they have a form that they have to fill out, their ability to move between those two would be really difficult. And the last cognitive one I'm going to touch on is communication. We often talk about receptive aphasia, the ability of the person to take in information, whether that be verbal or written, and then expressive aphasia, which is the ability of the person to come back with a response, to formulate a response and to express it. And quite often you hear about word finding challenges after a brain injury. So someone being able to actually locate the brain as they're locate the word as they're thinking and to express that. And you can imagine that that's very difficult. If someone knows this information, might be information they've spoke about for years, it could be a very basic word like desk or chair, and they just can't find the word that they're searching for. So it can be very frustrating for them. Then behaviorally, they can have social awareness. This is sometimes referred to as agnosia. So that's difficulty in perceiving and understanding facial expressions, body language, or voice intonation. So, sometimes we talk about reading the room. So someone with a brain injury, they might not be able to look around at the room and think about the participants that they're communicating with and take in the information that's being given out. So they might not understand that someone's happy or sad or getting angry, and they might not respond appropriately to the situation. Then motivation, it's sometimes hard for them, even though they have a goal, they struggle to initiate the next step moving towards that goal, whether that be doing some paperwork or phoning someone, it's a challenge for them to do that. Control of emotions can be challenging, and impulsivity, and sometimes they have frustration challenges, and we often refer to this as low frustration tolerance. So their ability to manage those little frustrations in life is overwhelming, and they go from being somewhat frustrated to be really angry at basic frustrations in their life. Then the last one I'm going to touch on is physical. So people can have sensitivities. This can be either sound sensitivities or visual sensitivities. So being aware of that and saying, okay, how can we accommodate this? Would we help them by giving them either some sunglasses, by dimming the lights? Would they be helped by having some sound dampening headphones while they're waiting for our appointments, managing that? They can also have weakness or fatigue. And I would say fatigue is one of the biggest comments that I get back, and it's overwhelming fatigue. So it's not like they can take a 10-minute break and completely overcome it. So the best thing to do is to manage their daily routines with planned breaks and kind of getting a rhythm to their life so that they plan every day with routine followed by breaks. Balance can be impacted, as can coordination, and then neglect. So, neglect refers to a failure to recognize or respond to stimulation on one side of their body. So, it can be visual neglect, that they actually don't see one side of their field of vision. It can be motor, that they're not using one side of their body. It can be auditory, or it can be tactile. And you can imagine the last one. If you're not aware of one side of your body and there's painful stimulation that you're not aware of, you're prone to injury, right? So neglect can be a significant concern. So, what might you see in your interaction with someone with brain injury? These are all symptoms of brain injury, but what you might actually see when you're interacting with them is they might appear intoxicated. They might have those symptoms. They don't have good balance. They might be slurring their speech. They might be confused. So, all those things could be brain injury. They could have what appears to be rude behavior. So, they might interrupt you during discussions and come back with inappropriate comments. And if you reflect back when I talked about cognitive impairments in the last slide, if someone is having a challenge with processing information and they're having memory impairments, you can imagine that you might have talked through 4 points and they're still processing the first point under discussion. So you need to keep that in mind, that you need to slow down your conversation. You can write little cues on a piece of paper so that they're aware of where they are in the conversation. And I find one great trick is to say to them, what did you get out of the conversation, before you move on to the next? Because then you have the chance for them to actually say what they heard or understood, and you can fill in the gaps before you move on to your next point. They might appear uninterested or lazy or just not responding, and sometimes that's just fatigue. Sometimes it's motivation that they're having challenges with. They might want to leave, and sometimes this is just because they're overwhelmed by all of the information, the stimulation, the sound, the light. So just being aware of that. They might go off topic and they might perseverate on one topic. And so sometimes, once again, it's worthwhile if you've reviewed with them the topic and you've written some cues down. And then if you can almost put a bookmark on the end of that by saying, okay, we've talked about this item, now we're going to go on to this. But just so you're aware, they might perseverate and they might confabulate. So they might create memories that aren't completely accurate. They might have repetitive questions and behaviors. That goes back to their memory. They can present with paranoia, agitation, some aggressive tendencies or mood swings, and they might have missed or late appointments. So it's really important that you not only make sure they write down appointments in their calendar or put them in their phone, but you also send cues, reminders. So you might call them a couple hours before the appointment and just say, just remember we're meeting in, a couple of hours, to give them time for travel and getting ready. And then there might be lack of follow through. Once again, this comes down to, can you set up a structure for them with chunking information so that they can follow through? Because if you just give them a task, such as fill out an ODSP form and send them on their way, that might be too overwhelming for them. But if you can give them some chunks, that will start them going. I'm going to hand it over to Kathy now, and she's going to move on to the coordination with other agencies and resources.
Okay, so now that we kind of have a sense of what a brain injury is and being able to recognize it, we're going to move on to how that impacts individuals who are involved in other systems. So within the green bubbles, what we know from a lot of the research that's been done and what the data shows is that there's a higher prevalence of individuals who have had a brain injury within those settings. And what that means is that for those of you who are working in one of those fields, is the likelihood is that you have already been working with somebody or are currently working with somebody who has sustained a brain injury. the important thing to consider is that sometimes the person themselves is not aware of this. So there are many people in the population who have undiagnosed brain injuries. Many of those tend to be more on the milder side, but it does mean that they're not always able to make that aware for you. And sometimes there is a mimicking of all those symptoms that Connie was just talking about in other facets of life. So sometimes the brain injury can get overshadowed by that. You can't know what you don't know is really talking about the domino effect that can happen. So we know that there are a lot of people who aren't aware of what a brain injury is, and that's for a variety of reasons. But if we kind of start at the first domino is that if you don't know the signs of the brain injury, then you're probably not going to recognize that you're working with somebody who may have sustained one. And then that's going to lead to some misinterpretation of their presentation. So a lot of those points that Connie was talking about, how it's easy to misinterpret why somebody is acting in what appears to be a rude manner, or why they're not getting back to you when you've given them information several times. Because of this, you may not realize that the person can benefit from simple accommodation. So we've tried to give a few tips today about how you can sometimes just change things, even just by providing, something in written form as well as verbal form, providing a phone call for a reminder, things like that. And then if you're not doing any of that, you may then suggest some appropriate referrals that can be made, or maybe some resources that can help that individual. And then again, as I mentioned, it complicates the fact that some people are not aware that they even have a brain injury. Because of this, what we often see is people who are lost in the system. So a lot of the factors that we talked about that are symptoms of a brain injury are invisible. And I don't think this is a new fact, particularly for any of you who are working in the field of mental health. You sometimes can't see what the issues are that someone is dealing with. But what that means is then people are not identified, or maybe their complaints aren't seen as pressing. So it's, sometimes that overshadowing effect. And due to a lot of the cognitive issues and even the behavioral issues, particularly with memory and organization, when they're missing appointments or they're not coming back to you with any questions, a lot of people may assume that they're dealing with the information fine on their own, or maybe that they're just disinterested and not wanting the assistance because they're not following up. And a lot of times there's the service mentality of we don't serve that diagnosis. And then this has people falling through the cracks when they're bounced between agencies. So for instance, if you are somebody who's working in an addiction setting and you suddenly become aware that you now have an individual who has had a brain injury, sometimes there's a feeling like, well, we're not expertise in that area. We're going to refer this individual, which is a good step. And then what may happen on the brain injury side of things is they're saying, well, this individual is struggling with addictions right now. That's the support that they need, and kind of getting sent back to where they started or sent back to another type of addictions help. So as we go through the talk, we just want to kind of talk about a little bit more bringing things together so that we're not losing the individuals. Part of this is just identifying brain injuries. So even we know that a lot of you won't have maybe the benefit of a diagnosis, and that's again for maybe some communication issues with how information is shared. So again, you're not going to have that upfront diagnosis in front of you. And even if you do have that, you may not have the full picture of what's going on with the individual. When you are dealing with how the person presents, if you have a better understanding of brain injury, so hopefully after today, you'll have a little bit of knowledge that'll kind of tweak that, to ask more questions, get a little bit more information. Then it's going to help you to recognize maybe some of those presentations that we've talked about, and then maybe make some of those simple changes so that the person can get the care that they need. We know brain injury can be very complex. So if you are identifying some of those, it is just going to really help you. I don't think I've ever heard any frontline workers saying that they haven't appreciated having the education and that information, because at the end of the day, it helps you to do your job a little easier. We know that individuals with a brain injury require a little bit more follow-up and sometimes more intensive support. So again, they may need, if you have, for instance, a program and you traditionally run a 6-week program with set, hours per day, because of the fatigue and the cognitive load that puts on someone with a brain injury, they may need to be in the program for a longer period of time. They may need to repeat the program twice or 3 times to get the same value that somebody who without a brain injury can go through it just once within that time frame. And then if you are working with an individual, and we've just kind of pulled out someone who in a mental health or addictions diagnosis, and they then sustain a brain injury after you've just started to work with them, being aware that you may need to change the way that you've been providing the treatment for them so that they can continue to benefit from your services. We also wanted to point out that unfortunately, in the province, there aren't really any ABI crisis beds. So when somebody with a brain injury is undergoing a crisis in the community, usually what happens is it'll be police or some of the newer mental health units that are going out. And if it's required, then what happens is this individual is generally taken to an inpatient mental health unit at a hospital. In some cases, individuals are seen in forensic units, but there's no kind of just ABI. So even though the person may not have a mental health diagnosis, this is where they're going to be getting that initial set of care. And that's another area where we really want to see that those individuals are also aware of what we've talked about with regards to recognizing brain injury and being aware how to provide some care to this person to kind of get them through that crisis, and then kind of can look at even contacting a navigator or looking at some resources for how to get this person some brain injury assistance. The good thing is that there are screening tools available. So today we're going to just briefly touch on the HELP screening tool. The reason we've chosen this one to share is because it is simple and it really was designed for people who work outside of the field of brain injury. The important thing to remember is you're not being asked to diagnose somebody with a brain injury, so you're not doing a medical screening or assessment. You're going to be asking some questions that may let you know that this person may have sustained a brain injury, and to then kind of put into the back of your mind some of those tips and tricks that we've been talking about. So how do I maybe have to change the way I'm communicating with this person, knowing that in going through the assessment, I've determined they may have had a brain injury. And it's also a tool that's widely recommended through all the ABI Navigators and also through the provincial ABI network. And then the link here will take you to having the ability to print out some of the forms. So when you print it out, this is what it's going to look like. I know for our purposes today, reading all of this is challenging on the one slide. Essentially, what we want to point out is one, it's a one-pager. So the questions and the scoring are all on one page. It's called the helps because these highlighted letters are gearing towards asking some questions to get some information about a person's history. So the H is centered around asking if you've ever been hit on the head, if you've ever hit your head or been hit on the head. And then usually under the question, there's a little bit more information that helps kind of guide the conversation. And I should point out, it really varies. So some people like to do the helps by kind of pulling out the sheet of paper, asking the questions, ticking off yes or no. Some people like to make it more of a conversation, and again, that may depend on the person in front of you, what they're comfortable with. The E is going to be more about that medical piece. So have they ever been seen in an emergency room, at a hospital, or by a doctor because of that event? L is about loss of consciousness, and then it just expands with some other phrasing. Not everybody is aware or familiar with what does that mean if I've lost consciousness. The P is the one question where you're going to do a little bit more than just a yes or no. So it's going to go through some different symptoms that somebody may have experienced at the time or are still experiencing. And you would go through them and then check off the ones that they're indicating they're struggling with. And then the point of the S is to bring in, if we go back to that traumatic versus non-traumatic injury, it's trying to pull information about non-traumatic injuries. So, these are the ones where, about viruses, a medical condition, so like stroke, seizures. So once you've gone through it, at the bottom, it'll walk you through the scoring. And then again, if somebody does happen to screen positive, there's a few things you can do. So one, you may just want to use it for your own purposes in working with this individual, knowing that you may have to, again, change a little bit what you're doing. You may want to look into some resources that you can refer this person to get more help. The other thing you can do is also provide them with a copy of it. And ask them if they know, have they ever actually been diagnosed? And if they say no, to maybe help them to the next step of maybe getting some medical confirmation of an injury. It's not always easy to get that for the mild injuries, particularly if a long period of time has passed. But with someone with a more involved injury, if they were to have some medical scans like a CT scan or an MRI scan, usually even older injuries will show up with that and show some confirmation of it. And that can help people to get some further access to services. These are just some examples of how HELPS has proven helpful throughout the province. So I'm not going to go through all of them. I do want to just point out the top one, which was done in Waterloo, Wellington. So the ABI in the Streets is a program that was done for homelessness settings. And they started off by just approaching a shelter in the area and asking if they could complete the HELPS. And at first there was some hesitancy. The shelter felt that, we don't deal with that population. They didn't really see the need for it. They did, however, consent to having it done, and they found a very high percentage. So well over 70% of the individuals they were seeing were screening positive on the HELPS. So this has now led, and again, it wasn't an overnight thing, but it has led to them being able to now expand on some programming for this setting. And they now have workers embedded in the shelter system. So I'm going to pass it back to Connie. We're going to touch on each of those areas on an individual level. I know I'm just mindful, so we're about halfway through the talk, but we're going to kind of go through each of the settings and then pull it back together to wrap it up.
Yeah, so what we're going to do with each of them is try to give a real practical resource that you can walk away with that will be in the slide deck. So when we look at ABI and justice, just to be mindful of the fact that the trajectory of criminal justice right from the first responders to interactions involves a very complex social interaction. So quite often these are very fast discussions. Sometimes it's legal language, so it's almost like learning a whole different language and trying to process all that information. So you can imagine, based on what we've discussed, how challenging that is for someone with a brain injury. And the lack of identification early on can be a contributing factor to the higher incidence of persons with brain injury in the justice system. When they're not able to process their information, maybe they're perseverating on one aspect and they can't respond to things, they can't come up with the language that they need to respond to things, that can cause them to be more involved in the justice system than may be necessary. So, part of the challenge of some of the solutions is there's limitations. And so, there can be agency policies that limit communication so that the information about their diagnosis and the background and things that have helped them might not get to the individuals that would be able to implement them. There's inconsistencies in education and training of individuals working in the health system, in the court system, so they might not know about brain injury and some of the accommodations that would easily overcome the challenges. There's a lack of neuropsychological assessment resources. So this is an assessment that's quite routinely done with someone with a brain injury, and it really highlights what are the impairments or the functional challenges a person is experiencing from a brain injury, but it's quite costly, and even if someone can afford it, there's still an extended waiting list. And then there's limited or non-existent ABI services in the justice system, so that even if they're identified, there are not always resources available to them. And right now, there's no specific classification of brain injury in the criminal code. So it's currently listed under mental disorder. So you can anticipate that that would result in the person having limitations as far as being able to access resources, rehabilitation needs, things that would support them. So because of that, the individual is likely to reoffend. So here's some factors to consider. 42 to 66% of male inmates and approximately 33% of female inmates have at least one brain injury. Recidivism is higher in this population. There's a higher risk of re-injury within detention centers. There's a lack of consistent training for staff. These individuals are less likely to have discretionary release, and there's a higher incidence of disciplinary action due to cognitive and behavioral challenges. So looking at some positive steps forward, there is the ABI Justice Toolkit. So this is a great resource that I would encourage you to check out. It has a caregiver or a section for caregivers, health professionals, people with brain injury, and a separate section for individuals that are working in the legal system. And the latter one has very concrete tips and tricks to making meetings more accessible. It has printable resources to support clients. The other two at the bottom that I'm going to highlight is the Toronto Bail Court pilot project that's happening right now. So Elizabeth Fry Society is in the process of trialing an ABI Bail Navigator. And this is really to do that help screener with people who are going through the bail process, to identify individuals who have had a brain injury, and then to support them with the best resources to help with the transition as they enter the community. And the last one is Brain Injury Canada has a pilot project, and it's currently training all of the correction workers in British Columbia. It's been very positive feedback from that, and it's expected that that will be rolled out across Ontario. We've listed some learnings from others. These are videotapes that anybody can access. They're really practical tapes too, to give you lots of information both on brain injury, but also strategies to support individuals with brain injury in the context of the justice or legal setting. Next area I want to talk about is ABI and intimate partner violence. And, you know, there's a number of ways that TBI in the context of violence against women can be distinguished from other TBI contexts. First of all, women experiencing violence may endure frequent and cumulative incidents. And so we talk about the second impact syndrome with brain injury, and that's when there's a second blow to the head while the brain is still vulnerable from a previous brain injury. So you can anticipate in this particular population, there could be repeated brain injuries. And the resources and support for brain injury due to violence is sparse. And quite often, the professionals might not recognize that a traumatic brain injury exists in that setting. The effects may be mistaken as psychological abuse, and so it might be overlooked for brain injury. And the presence of TBI may impact a woman's ability to stay safe. So some of the things that she might want to pursue as far as getting employment, housing, they actually might increase the possibility of re-victimization. And the diagnosis of brain injury could be used against her. It could be weaponized, and she might be identified as an unfit parent. So a lot of challenges in this particular population. The same strategies that might help her at home might also cause her harm. So if she's making notes to support her memory, that actually might be a problem in the home and be unsafe. So some of the facts to consider: the likelihood of brain injury is high, as up to 90% for those that are hit in the head, face, or neck. Some of them are thrown against an object. Strangulation is something that I think there's a better understanding that this is causing brain injury, but I think that's relatively recent in the last 2 or 3 years. And then those that are violently shaken, right? You think of shaken baby syndrome. So this can cause a brain injury. Up to 75% of women have sustained a brain injury. That equates to 1 in 8 women in Canada. And a lot of people don't connect that they've had their abuse and this has caused a brain injury. And my experience has been that when people are diagnosed, in a situation like this, it's actually a relief to them because it starts to put the pieces of the puzzle together. Why am I having problems with memory? Why can't, why am I having trouble finding these words? It starts to make more sense. Another challenge is that service providers aren't always familiar with the signs of ABI, and many suffer repeated brain injuries. And then also you need to consider the impact on the children that are in that environment. So once again, we've put a number of resources that would be helpful for you. The first one, SOAR, is a project out of BC, and they have lots of resources. They've adapted the help screener that we talked about to take into account strangulation as a factor for brain injury. But these are all resources that you can look at after this presentation. So one of the second ones that we want to talk about is ABI and mental health, and I'll highlight that there's kind of this triad that there's often acquired brain injury, mental health, and substance use kind of go together. And so you need to be aware of that if you're seeing one, you might want to be thinking about the others. And some facts to consider is that many individuals who suffer a brain injury are also dealing with mood disorders like depression, anxiety, PTSD, or substance use disorder. And, that might not be evident in the early stages of recovery. And so once again, as time goes along, Kathy already mentioned, you kind of need to tease it out and think about, okay, what resources would best meet their needs at this point. A high percentage of these individuals do seek out mental health services, and up to 75% of people attending programs for concurrent disorders have a history of brain injury with loss of consciousness, so a very significant brain injury. Those with TBI are up to 4 times more likely to develop serious mental illness, and a history of brain injury increases the risk of suicide by 3-fold. And underlying mental health disorders may be exacerbated following an injury. So, maybe they had depression before the brain injury, and then they have the brain injury, and the mood impairment just is exacerbated from that. So once again, we wanted to talk about some of the positive steps that have taken place. And there's, mental health crisis units. Some of the navigators sit on the response and crisis tables. There's an ABI guide for Ontario health teams around mental health and addictions. There's collaboratives in Ontario. In Southeast Ontario, we have the ABI Mental Health and Addictions Collaborative. And there's advocacy efforts with the Mental Health Commission to consider ABI as one of the things that they have to think about in that pathway. And so there is movement in starting to recognize that ABI is a significant factor within the mental health population. And once again, we've put up some resources that are available to you. The post-traumatic stress disorder in the context of acquired brain injury is available on the neurotrauma care pathways. And this is a full webinar training. It's about 3 hours. All the PowerPoints are available for anyone. There's no cost to it. So these are resources we hope that you'll make use of. And ABI and substance use, like I said, it's quite prevalent in the brain injury population that substance use is a contributing or a concurrent factor. So substance abuse is a risk factor for TBI, and TBI is a risk factor for developing substance abuse. So they often go hand in hand. As many as 1/3 with addictions sustain a brain injury, and up to 20% with no prior use turn to substances post-injury. 25 to 50% of individuals seeking addiction treatment have experienced a head injury. And ABI decreases the ability to monitor intake. We talked about judgment and impulsivity, and it increases the sensitivity to the effects of those substances. Those with prior addictions often return to use after the 2-year mark. So maybe they've gone through a rehab program, they have a brain injury, and then they get back into the community, and life events are there that impact them, and unfortunately they often return to addictions. So the need for support is an ongoing long-term need. Once again, we've put up some resources. Due to time, I'm not going to go through them at length, and we'll just move forward with the next slide. So you can imagine, in the ABI population, Homelessness is a significant factor. People who've had a brain injury, particularly if it's a severe brain injury, maybe they've lost their job, their family has maybe not able to cope with some of their behaviors. And so, there's a very significant homeless population. So up to 58% of homeless men and 42% of homeless women have a brain injury. And up to 70%, their brain injury actually was prior to their homelessness. So you can see how the challenges as a result of the brain injury was what created the series of events that led to their homelessness. Of those unhoused, 70% have moderate to severe brain injuries. And a lot of these people are unaware that they have a brain injury. Nobody has stopped to support them in that. So the last area I'm going to talk about is ABI and homeless. Oh, sorry. Just these are the learning things that we have from others. So we'll let you go through them together. And I'm going to pass it back to Kathy to finish off and pulling it all together.
Okay, so now that we've kind of gone over everything separately, we want to now tie it all together. So I want to think more about that collaboration and knowing that people often don't just have one of those factors involved, but a lot of people have more than one. So we don't want to be educating in silos. So when you're doing the work that you're doing, trying to think that it doesn't have to be all or nothing. So even if you know that you have somebody that you're working with and you're feeling like I can't provide enough of the support that this person needs, can you find somebody who will do a one-off consult, or is it that your service, can they provide a one-off consult to at least provide some support to one of those other areas? We've talked a lot about how there's these interactions and the need to kind of peel back the onion layer. So the link that we've put here is actually from Alberta, and it's just a nice short clip that talks about the need to kind of look at what's the most pressing issue that you need to start with. Try to work with the person on that, peel that layer back. What's the next most pressing issue, and kind of work your way down. And often the brain injury ends up being what gets down at the center and what you really are looking at to help with. And that goes back to managing what's in front of you, learning about their cognitive challenges and accommodations. Again, we want to avoid that bounce back between service providers. And then thinking outside the box, so really trying to be creative. And that's sometimes where contacting a navigator might be helpful. Trying to think about what are some other things you can consider. We just put an example of kind of those cognitive safety assessments. A lot of times when someone has a physical injury, it can be quite easy to think about what they might need, what assessments are required. But when it's those invisible factors, what are some of the things that you might want to think about? I'm not going to read this word for word, just that this was a really amazing case where there was an individual who had a lot going on besides their brain injury, ended up with justice involvement, placed in a mental health inpatient unit. The navigator became involved, was able to pull people from all these different areas. And eventually, with a lot of hard work, it wasn't an overnight success, they have been able to have this individual now living in the community independently with some community outreach. So really good success story. And then it's that holistic view of the individual. So not just about those comorbidities that we've talked about, but going kind of a step further of looking beyond just the healthcare. So we've touched a little bit about a lot of individuals who have sustained a brain injury may not be able to return to paid employment. And that puts a lot of financial stressors. It leads to them maybe needing to access food banks or shelters. They, because of their injuries, whether from physical or cognitive means, may no longer be able to drive. They may get lost within, if you think of the bigger cities and their transportation systems, it may be really difficult for them to manage that. And then, having to think about, so what are those resources that they need? And then really navigation needs to be about avoiding touch points. So rather than maybe sending an individual away with 10 different resources, is there, a way that you can maybe help to at least make that one next connection for them to make it a little easier? And then we do have pathways that exist. Brain injury has established one. We know in mental health there's a pathway. So in lots of services, we have these set pathways that are really system developed, but not to lose sight of individuals who are going through that pathway, because maybe for a certain individual, that pathway has to look a little bit different. One of the things that we've done is we've created a resource that is called the CentralLink ABI Resource Library. So this is really a comprehensive online resource hub. So what we've done is we've kind of taken some of that information from the slide before and we put it into one resource. So it's a one-stop shop where you can get a lot of that holistic information. Right now, I mean, it started as a pilot project in York Region, and it has since grown to now include 4 of Ontario's health regions. So you'll find the resource has the Toronto area, a couple of areas in central Ontario, some of the areas in eastern Ontario, and then all of northeastern Ontario. And we're currently working and hoping that by the end of this year, we'll be able to include West Ontario health region and the Northwest area. So a lot of these we've touched on, so we wanted to make it about the holistic view, the whole person. We wanted to be able to include their support circle. So there are resources not just for the individual, but also for any caregivers and for professionals who interact with them. When you go on to the site, you're going to see 5 main categories. So acquired brain injury supports and services, community supports and services, specialized supports and services, accessibility and healthcare. And from there, when you go into that section, you will see that it's further subdivided so that you can kind of narrow down what you're looking for. So some people are using the resource because they know that they want a specific resource. So for instance, perhaps you're an individual and you're looking for information on addictions. So you would know that you're going to go to that area. But the way that it's set up, it also allows for kind of some browsing so that you can consider maybe resources that you haven't considered. And then this is just kind of what it would look like when you actually go into that subsection or that category and you're selecting. So no matter what region you are looking at, it's all going to be set up the same. You're going to see resource name, a brief description. There will be a direct link to a website. If there is contact information of a phone number, an email address, it will, or an email address, it'll be there. And then it will state whether that resource is a national, provincial, or regional. And all of the areas will have the national and provincial ones repeated. It's just the regional ones that will be specific to the area. So we're always looking for help to spread the word on this resource. Feedback has really been positive, and that's why it's expanded so well. But basically, we're asking for you to share the resource name and the web address with your peers, to distribute the postcards. So that green card that I started with, we do have hard copies, but for we know that getting that out to people is hard. So on the website, you can print off a 1-pager. Posting it onto, if you have a resource section on your websites, if you can help by including the link there. And then also talking about it with part of your care or discharge plans as part of your therapy sessions. Again, using some of those resources to help get people to the next step. So basically, we want to wrap it up by hoping that you're going to go away with some of these takeaway messages. So our hope is that you now have a better understanding and are able to recognize an individual who may have a brain injury, that you can respond to them better. So you're going to have a few tips and tricks that you can take with you, that you can refer individuals on to the next step, and knowing where to refer. So again, you might use that Navigator contact list. You might go to the CentralLink ABI Resource Library where you'll find a lot of that. And we really want to point out, don't refer and run. So what we often will see is people do a great service by making a referral, but then they often might discharge the individual. And by the time that that referring agency is able to get back to kind of have some conversation, the file is closed, it's no longer easily accessible. So if you are making referrals, try to keep a file open until that next step. And again, that's going to help the individual to not get lost and fall through the cracks. Remember, can't versus won't. Obviously, there are going to be individuals with a brain injury who won't do things, but I think if you can just, take for granted that in most cases it's because they can't, because of a lot of those symptoms that Connie went through. And knowing that if you are working in a non-ABI setting, that you still can support people with brain injury. And then just reaching out. So letting us know what you're working on. We're always wanting to know about what resources are available that we can help people with as well. I'm not going to go through these. We have a couple slides. We just wanted to demonstrate that, you know, for different factors, different settings, people have made use of the navigators, and it's been quite successful. And they found good value in reaching out to us. And with that, we will leave some time if anybody has any questions. If we're not able to get to questions today, we've left our contact information. You can certainly reach out to us, and we'll try and get back to you after the webinar.
Wonderful. Thank you very much, Kathy. Thank you very much, Constance. First, Constance, I would like to apologize. I introduced you with Connie. I hope that was okay.
That is
And
quite all right.
okay, thank
I
you.
go by both.
Okay, wonderful. And I did mess up the where you came from. I said Champion Acquired Brain Injury System Navigator, but it's Champlain. So I apologize for that too. I don't know why I mixed up some letters there. So I just wanted to correct that. I do have one question in the chat. First of all, that was a fantastic presentation. Somebody asked if we can get the PowerPoint presentation, and you did say at the beginning that you would be sharing that. So I did respond to that in the chat that yes, the presentation will be shared. So first question, if you don't mind. So I'm not sure if this was mentioned when you first talked, but someone might have missed it, and they would like to know if they're wondering if the FASD, the fetal alcohol spectrum disorder, can be included in the ABI, even though the person is born with FASD. Often the people who I work with who have FASD also have other complexities, such as childhood trauma, intergenerational trauma, CP, TSD, and all the signs of all of this info today feels applicable to working with someone with FASD, if you are able to.
Yeah, so we did have it on the slide. We didn't verbally point it out, but on the slide that talked about traumatic versus non-traumatic, at the top was a definition of what an acquired brain injury is. So an acquired brain injury has to happen after birth. So it's not a congenital disorder. And it wouldn't be, so something like a dementia, Alzheimer's would not fall into that category as well. That being said, the definition was kind of set up more from kind of to have a medical perspective, like an actual definition, and it kind of guides some of the support somebody can access. But I think the person is correct in that there still is going to be similarities. So even, for instance, someone with a developmental disability would not necessarily qualify for brain injury services. But some of those symptoms, some of the difficulties that people have with some of these different factors. Someone with PTSD, there's a lot of overlap. So that training that, Connie talked about kind of goes in depth that. So I think the information can still be applicable, and still some of those tips might be helpful. And then sometimes those congenital factors can put somebody at risk for having then a kind of formalized brain injury later on in life, which would then, it complicates it, but as far as what they might be eligible for services would change. So hopefully that clarifies a little bit.
That was a very good question. I don't see another question, so I was wondering if I could ask a quick question as we round off this session. And you might have also mentioned this too, but is regarding the HELP screening tool that you spoke about. First of all, was that just is that for anyone to use, or I noticed that you also talked about using it in detention centers, but is it for anyone to kind of help identify?
Yeah, so the HELPS was designed so that people who don't work in brain injury would have a tool.
Right.
So that's why like it kind of has, you know, questions, and it tries to quantify or qualify or give more explanation around what you're asking so that it can help guide the professional who's doing it. And again, it's not a diagnostic tool. I think, you know, some people worry about, you know, well, I can't go away and say, you're not ending that conversation by saying, oh, you have a brain injury. You're ending the conversation by saying, it looks like you've had some events in your life which may have resulted in you having an injury to your brain. Maybe it would be good if we could figure out how to get some more information for you. And they are like if anyone goes back to the slides, so there have been some preliminary discussions within detention centers for the nurses to start doing that helps.
That's great. I really am thrilled by the label. I don't know if it's right to say label, but the idea of you guys being navigators. I think that's very fitting with the fact that all the steps that you do in helping people navigate through the process. So I think that's quite smart and fitting with what you're doing. I just want to know one last thing, and I see another question here, but one last thing. How do you help or navigate someone who has no idea? You touched on this briefly, but they're not attributing anything to an acquired brain injury. So I guess the first thing that pops to my mind are maybe a child who wouldn't know or know that something happened when they were smaller, and it could attribute to what's happening as they're older.
Yeah, and I think it's a bit of a puzzle, and sometimes you backtrack. And I've
Yeah.
certainly had some people who have come across my path through parole officers who said, you know, we just wonder if there's something, but nobody had really looked back. And one in particular, I was able to access their medical documents, and they were in their mid-20s when I did this. And it turned out when they were 4, they were a pedestrian who'd been struck by a motor vehicle and had been in a coma for an extended period of time, but nobody had attributed all the challenges they were having in life back to that. But when you looked at it, they were very consistent with brain injury symptoms. And so we were able to support them. And this young gentleman did quite well with getting the support for brain injury.
Okay, thank you very much. I have one question in the chat before we leave. I think we're almost at the end here, but how can we help someone with ABI who has been charged with an offense? I mean, I think you went over this very generally, but here's the question.
Yeah, and I think that's something that we're exploring actively, you know, along with some other agencies. And that's one of the reasons Elizabeth Fry is starting this, you know, Toronto Bail Court Navigator to identify people who might have brain injury and then to provide them the active supports. Another project that we're involved in is looking at how to make some court documents accessible to someone with a brain injury so that they would be able to understand the information, retain the information, and be able to respond. So I think there is some movement in starting to identify that as an environment that we can support and provide better services to.
Yeah, and I think also just I know it's hard in some of the courts, but all of them should have accessibility coordinators. And a lot of times I know that's on the side of somebody's desk, but recognizing that somebody with cognitive issues really should have access to accessibility. So a lot of times, I mean, for speech, you know, just all those processes we talked about, the process within courts is so complicated for someone with a brain injury. They really need somebody who can break it down for them and help them through it.
Thank you. I
And
hope.
sorry, I'm going to just highlight, going back to that ABI Justice Toolkit, they do have some really great resources for the legal setting and the justice setting. So I'd really highlight that one.
Thank you for mentioning that again. The toolkit, which we'll find when we get your slide presentation to see all those resources, those wonderful resources. I think that is it. Hopefully that question was answered. I thought you answered it very well. We've reached the end. Thank you for staying that little bit longer with us, Kathy and Connie. So again, very much appreciated everything that you were doing. You're wonderful. I'd like to let everybody know that our next presentation is starting about 1:20. It might be a bit about 1:25. and that's going to be on social reentry of Black, gay, trans, and non-binary and same-gender loving people. Again, Kathy, Constance, thank you very much. Mitrik, merci, thank you. Everyone have a wonderful afternoon.